Can you see the slides okay?
Yep, definitely.
Right. All right, well, let's go ahead and get started then. Everyone, thanks for joining. I'm Sunil Kripalani. I've been leading this project with nursing homes across our area. And what we thought we would do today, since this is actually our last scheduled webinar, is provide an overview and review of the whole project, a reminder of some of the methods that we used, and also share with you some results from this great work that everybody's been participating in, and then some resources for going forward. And so I call this looking back and looking forward on our quality improvement collaborative that we've been part of together. And really just presenting on behalf of the whole team, and many of whom are on the call today. Do you want to start with some required financial disclosures? Basically, we have no relevant conflicts of interest to disclose here across our team members. And the next most important thing is I do want to begin with a thank you to everyone from our whole team. We've really enjoyed working with facilities in the area and hope that you have too. These are all our team members pictured here from Vanderbilt, several of whom you may know through your personal interactions. And really on behalf of everybody, thank you for being part of this important collaborative to improve the health of nursing home residents across our state. So what I thought we could do today is acknowledge and discuss some of the challenges in doing quality improvement work during a global pandemic. Review the quality improvement collaborative approach that we've been taking through this project, and also what were the main results that we've found so far. And then I want to be sure to share resources that are available to you all as you continue on your journey of improvement, because this is not a destination that we ever fully reach. And I want to be sure that, as the time period of this project comes to a close, you have at your fingertips resources that can help you continue training, continue on this QI journey. You all have been living this, and do want to acknowledge the challenges over the last 3 years now of this pandemic. I think we've just crossed the 3-year mark. Early on, one of the biggest challenges was all the uncertainty of it. We also, particularly in the nursing home setting, had to confront a high burden of illness and high mortality. There was a time when 30% of all the deaths related to COVID-19 were in nursing homes. And in part, early on, that was due to lack of adequate support, lack of adequate protective equipment. And all that, of course, caused a lot of stress on staff, which led to turnover, which led to more challenges. And it wasn't just about losing colleagues and friends who, weren't working side by side with us any longer, but also losing the experience of those personnel. And many people might have been leaders in facilities, and losing that experience made it hard to continue providing high quality care, but there was still an expectation and a need to do that. And that's hard, of course, when constantly feeling like we're putting out fires. So we know from studies that have been done across the country that nursing homes with a lot of COVID-19 cases saw higher mortality rates in residents, as you might expect, a higher degree of functional decline. One thing that surprised me in looking at work from around the country is that across all nursing homes, even nursing homes that didn't have big outbreaks of COVID-19, residents suffered more weight loss and more depressive symptoms. And maybe that was because of some of the isolation. Maybe it was due to some lack of support that they had particularly previously been able to receive through shared meals and things like that. But the pandemic really affected the health of nursing home residents around the country, and certainly in Middle Tennessee. So all of these things, fed into the approach that we've taken through this project, which, again, I want to acknowledge the funding from the Civil Monetary Penalties Program to give back resources to nursing homes around the Middle Tennessee region. We started this collaborative doing work in August of 2021. We're about 2.5 years in now, and about 18 months in now. And our approach was not to try to bring new tasks and new responsibilities as part of participation, but rather to partner one-on-one with nursing homes, help them take stock of, what assets were there in the facility, what experience, and what were some of the priorities. Let's share some best practices across each other. Let's do education and support the educational needs of staff. And let's try to work hand in hand with facilities to help do the great improvement work that maybe you're already doing or are required to do by CMS. And so we provided free education and expertise to support those quality improvement projects to help fulfill and meet CMS requirements in a way that was really hopefully driven by the facility's own priorities. And so I wanted to share with you now, what this all looked like over the last 18 months. Just by the numbers, there were 56 nursing homes across the greater Middle Tennessee area that participated. We're really thankful for that high level of involvement and engagement. Our team held more than 250 meetings with participating sites. There were more than 25 PDSA cycles completed across participating sites and dozens of other additional plans that were created and initiated. Here's a map of where all these sites spread across the region. You can see most of them are based around Nashville, Middle Tennessee, Central here. And as the project went on, we actually started going a little bit farther and farther out, beyond the traditional borders of Middle Tennessee, a little bit into Jackson, a little bit into Chattanooga, Etowah area. And in part, that was because of the great partnerships of some large regional corporations that had facilities in those areas and asked us if we could extend the work into those sites. I did also want to share a little bit about the projects that sites pursued. Again, we gave support to sites to pursue whatever topics were most important at those sites early on. And most sites chose to do some work around COVID-19 vaccination, education, and maybe some on-site events. Several sites chose to engage in nutrition support initiatives to help reduce weight loss. Medication management was a key aspect of this, whether it's improving medication reconciliation or streamlining medication passes to administer medications. Several facilities also took on fall prevention as a challenge that they wanted to try to address. And then again, in responding to some of the needs of facilities, we also had some programs around staff mental health, well-being, and addressing burnout and how we can best support staff within facilities. Throughout the whole project, we followed the Institute for Healthcare Improvement model for improvement. I want to go over this again also as a review and refresher and reminder of what some of these steps are. And then we'll share with you a couple of specific projects that sites pursued. The first step in the model for improvement is to form a team of people who are going to lead that initiative forward. And then the next step is to analyze, how are things going right now? What are some of the problems? What are the processes involved? And then work toward defining a really specific project aim. Identify and measure, because if you can't measure it, you can't improve it. And then plan and do a test of change. Try something out, see how it works. Evaluate those results, and then repeat some kind of cycle. So visually what that looks like is shown here. In the IHI model for improvement, it's really designed to be a simple model for conducting what can be really complicated work. Again, the first step is to think about, what are we trying to accomplish? And this model helps us remember to start with a goal, not with a solution. Also, we have to understand, how will we know if a change is an improvement? we've got to think early about defining, what would success look like? What metric are we following? How are we doing right now? And where are we trying to get? The process analysis can help us also understand what changes could we make that will result in improvement in that metric. And all this leads to a plan, do, study, act cycle. And we plan an improvement, do something very concrete to try to take action. We evaluate what effect that had, then we reflect. We reflect on what we should do next, whether we should stop doing something, whether we need to move something to a maintenance phase, etc. And so this fundamental approach really can help anchor all our quality improvement methods that we take. Do you want to say a little bit more about forming a team? This is, as I mentioned, something that occurs at the very beginning of the process. And we'll unpack each of these 6 steps over the next few slides. Sometimes we think about the responsibility of improvement being in the hands of one person. Is it going to be the director of nursing or the head of quality at the facility? A team around that person should include, not only a project leader, but also staff from different disciplines, a facilitator, and ideally some executive support, because everybody brings a unique perspective to that problem, either understanding all the contributing factors or some potential solutions. And so we've tried to encourage forming teams that include multiple representatives that bring those different perspectives to the table. If we think about the next step, which is analyzing the problem, I did want to share, again, in the spirit of review and reminder, what are some of those tools and how might they be used? So one very simple tool is a tally sheet. So let's say a facility recognizes that patients have a high rate of falls. Maybe they saw in their MDS report that their rate of falls in the facility is higher than other facilities in the area. A tally sheet involves just simply counting the occurrences of events, what were the circumstances around them, and grouping them into some sort of categories. And so in this case of a high fall rate, a facility might do a simple tally sheet and say, well, what are the circumstances around those falls? And that might involve some observations and simply just counting those circumstances in the case of a series of falls that might occur over a period of some weeks. And in this example, let's say this facility figured out, like, oh, a lot of these falls were associated with the resident attempting to toilet, but without assistance. And that was more than half of the falls. There were also several involving reaching for an object, a couple that involved tripping, another one where the resident had orthostatic blood pressures. So the value of a tally sheet like this might be to identify what were the most common circumstances and therefore what should probably be the first target of action to try to address that problem. There's another simple tool for analyzing the problem that we encouraged use of. And again, I'd like to remind everybody that this is a good strategy for your future improvement efforts. It's called the 5 whys. So here it begins with the problem. Falls are occurring at a high rate. Why is that? Well, in asking the 5 whys, you might say, well, residents are falling around times that they're trying to toilet. Why are they falling? Well, they're getting up without assistance to go to the bathroom and get back from the bathroom. Okay, well, why is that happening? Well, they're calling for help, but sometimes assistance comes slowly. Well, why is that happening? Well, there are a lot of people who are calling for assistance all at the same time, right around nighttime, and staff can't get to everybody, and they're all spread around. So staff person may be helping somebody over here on this hall, but 2 other patients are calling in another area. And all these things are kind of boiling up at the same time, and we're not able to really tend to everybody. And then by asking, well, why is that happening? Well, then in this process, it might lead to finding a root cause. Well, maybe the root cause is that when staff are in the rooms near nighttime, they're not offering patients proactively assistance to toilet. And so by asking the 5 whys in this made up example, a facility might get to something that they might choose to address, which could include scheduled toileting or engaging staff, like when you go into a room for a medication pass or some other kind of late evening check-in to proactively offer that toileting assistance while present to try to decompress all the simultaneous requests that patients might have otherwise. There's a third tool for analyzing a problem, which I just want to remind everyone of. It's called a cause and effect diagram or a fishbone diagram. And here it's a different approach. It involves, thinking about and really getting around a table and thinking like, what are all the contributing factors? Like from a staff perspective, this may be related to, training or lack of training. From the environment, this might be a cord that somebody's tripping on or the phone being out of reach. Policies, well, maybe there should be a policy around scheduled toileting that could really help. And a contributor to high falls might be the lack of a policy. There might be some equipment or materials or other miscellaneous things like timing. A lot of things just happening at the same time. And so sitting around the table and thinking about these as a team can help identify, what are the contributing factors? And then again, the purpose of all these different forms of problem analysis are to help identify a target for action. I can't intervene on everything all at the same time, but just finding one thing that looks like it might be amenable to some kind of intervention is a great way to start a project. So once you form a team, unpack the problem a little bit, it's time to move on to writing out the goal or aim of an improvement initiative. And we encourage using a SMART format. SMART means specific, measurable, achievable, relevant, and time limited. So it should be something concrete that you can hold yourself accountable to. It should be measurable. There should be some way of tallying or tracking with numbers, what is being changed. And it has to be achievable and relevant to the patient care, as well as time limited. A lot of these effective quality improvement projects are rapid, and I would recommend doing something that can be measured within 2 weeks to see if improvement is occurring. And that allows for rapid cycle improvement, as we call it. So I'd like to show some examples of SMART statements. Fortunately, Teams, I can't see everybody while I have my presentation slides up. I want to give you an opportunity to reflect on some AIM statements in a moment. So if you feel comfortable unmuting and just sharing your opinion, I'd love to hear it. A good AIM statement is going to be really crisp. If the team can't describe in 1 or 2 short sentences what they're working on together, then the task just probably isn't clear enough. We recommend using a format of like, we will improve something by a certain amount by a certain date. And that helps us be really concrete. So I want to put up a couple examples of AIM statements, kinds of things you might see if you're just thinking about improvement. I'm going to pause here and ask for folks to give feedback on this potential AIM statement, which says decrease fall rates in the facility. Does that sound pretty good to you? Welcome folks to unmute and just share your opinions. If you were trying to do an improvement initiative, is this the sort of AIM statement that would help you see if you're effectively working toward your goal? Let me put up the next one and we can see the comparison. So if you've identified falls are high in your facility and that they're occurring around toileting, the second AIM statement is a little bit more focused. So decrease the rate of falls with harm related to toileting. So now if your efforts are going to focus on that, having that in mind front and center could really be helpful. I might suggest also something even more specific. So here we've got the structure of we're going to improve something concrete, which the second example had, but now we're adding by how much and by when. Now, this provides us a great concrete goal and helps us identify, not only the type of improvement we're trying to get, but the amount and the time period for achieving that improvement as a team. So what do we do next? We put it all into action. And this is where the plan, do, study, act cycle comes from. So after we've formed our team, after we've analyzed the problem, after we've made a very concise, concrete goal, the next step is to identify what actions we're going to take and put it into practice. So, and these again are intended to be multiple small interventions. And the power comes from not trying to design the perfect change in practice all at once, because it may take months to get everybody on board for that. It's generally considered far more effective and practical and feasible to make small iterative changes. And so you might start with something simple. You should start with something simple. And then over time, as you take on the next cycle of improvement and the next cycle, it's okay for the complexity to go up because you're refining your approach to a problem. I'm going to ask Carol to jump in now and share examples of a couple of actual PDSA cycles that were done as part of this quality improvement collaborative. Carol, I'll advance the slides for you if you could walk us through these two cases.
Sure. And first, it was great to work with these folks. They were terrific to work with. We had a lot of fun doing these projects.
Terrific.
Okay, yeah. So this is a facility that early on they joined us just with an ADON who was relatively new to her position. So it was a challenge for them early in this project to get a full team together. It was really kind of just her and her director of nursing trying to improve the rates of UTIs that they were seeing. And in having this brief conversation, we realized that because the ADON didn't really fully understand how UTI cases were reported to the state, that really what they wanted to do, their goal was to make sure that they were doing the right things, to correctly report things to the state, to make sure that their numbers were actually accurate as they were reported to the state. So their goal was to use the McGeer criteria to reduce any inconsistency of the UTIs and to get with MDS, who actually did the data reporting to the state, to be sure that everybody understood the common goals for reporting a UTI case. That was the plan. They wanted 100% to make sure that they reported things the way that they needed to and consistently. So on the do portion, what happened was that the ADON got together with her MDS person, and that was the team. And what they would do would be to collect evidence around UTIs for a short period of time. The amount of time was February to April, just 2 months. They could expect only up to about 3 cases per month. So this wasn't a lot of data they would be collecting, but it was certainly a good start to figuring out their process. The goal was to get together, look at every case that came up, make sure that the McGeer criteria was met, yes or no, and simply track that. Tally whether or not they were missing anything, whether or not they were able to agree on all the points of who met the McGeer criteria. Now on step 3, which is the study, they actually sort of halfway through, we always recommend, the meeting halfway through to kind of take a look at how things are going. And so we did, and there was sort of an unexpected thing that had happened. They had added to their EMR a new template that required anytime antibiotics were ordered that the staff actually check the boxes for the McGeer criteria. So This was a really nice little easy case to be very successful in. So they had only one case of UTI in February, 4 cases in March. They all met the Madrid criteria. The goal was met, as we talked about this. And the interaction between MDS and nursing was new and helpful. They decided to continue to do that. It was unintended that the EMR came in and kind of saved the day to make things very consistent. But they had great learning about how the process went. Wasn't really, improving patient care so much as improving understanding and communication around the process. So they did make some updates to build on the data, make sure that over time they could continue to look to make sure all the McGeer criteria was being met, and it certainly was easy to do that at that point, and they considered it a great success. So the second case, though, it was a more traditional in that they took on the number of state-reported antipsychotics used in their building that didn't have the indications that the state wants, right? So they call it inappropriate indication. That's how the state refers to it. And this facility really wanted to make sure they were way down on any antipsychotics that were used that were not meeting the state criteria for an indication. So they found that they had 24 patients with antipsychotics total, and half of those, 50%, did not have an appropriate diagnosis listed. So what they wanted to do, their goal, their SMART goal, was to go ahead and reduce the number of antipsychotics given inappropriately by half. So within the time of this project, they wanted to have 6 patients that would have a change from an inappropriate indication to an appropriate one. So in the due portion, this particular cycle was actually kind of the second cycle of trying to get this done. The first was not successful. And in this case, what the director of nursing decided to do was to try to get the psych nurse practitioners and facility MDs to consider whoever she could bring up of really anybody who was timely for a visit. And she would make a sort of a suggestion. Hey, could we look at this patient who happens to have an inappropriate listing for possibly a gradual dose reduction and switch to something, bridging them to something that might help them to maybe reduce that. She wanted to have that discussion with the providers. And she was going to try to do this over the April to June months. But the new attending, as you'll see in the study portion, didn't really have a geriatric background, was not aware of the state rules around having an appropriate diagnosis, and that the psych nurse practitioner was very busy. So she never got them to come to one of our planning meetings in talking about this Plan, Do, Study, Act cycle. She really tried to get them to join in the middle. What they found is that there is generally no change. She could not convince folks to make any changes with this approach. And so in the ACT portion, this is where she really had a terrific idea. Then was the MDS folks, the director of nursing, and she did invite to a follow-up meeting, the study meeting, the psych nurse practitioner. And together, what they decided is that really you needed to be a little more selective about who it was you were going to even anticipate trying to do a gradual dose reduction. And they would select by the pharmacy consultants' recommendations, who also joined the meeting. So now we had a real team going on here. They suggested that we only focus on long-term folks who had a low-dose antipsychotic, and that they would do is to have the nurse practitioner, the psych nurse practitioner, make 2 visits, one to assess, make sure that this was going to work well, maybe assign a gradual dose reduction, and then a second visit to make sure things were going well, and then perhaps finish off the gradual dose reduction to perhaps discontinuing the medication. So to let you know, this cycle that you're seeing here was number 2 out of 3. And the third one, because they made a nice act, that is, it changes for the next cycle, the following cycle after this one was very successful.
Well, thanks for sharing those. These are good examples, and just want to draw attention to a couple of things that stand out here. And one is it's multidisciplinary. It really involves, folks working together, and then as you pointed out, also, sometimes the pieces don't fall in place exactly like you might like. And, you know, rapidly finding that out and then taking a direction that can work is one of the keys to these rapid cycles. So thanks so much for going over those. Things don't always go as planned, and it's a good example of how you can reroute um, to a more successful path. And I'm glad to hear this facility was successful in reducing antipsychotics. Um, so if we think about, what are some of the characteristics of successful interventions, as we saw from these two examples, they're often simple and small, and there may be a complex overall process. Breaking that down into smaller pieces and then targeting one thing at a time is a great way to make progress and then continue forward tackling other parts of that problem in future cycles. It's important to start with something that is low-hanging fruit. Success breeds success, and we want teams to be successful. And beginning with something that has a high likelihood of success rather than something difficult and risky is definitely going to get the team energized and be more likely to continue wanting to work in that area when they have that initial success. Part of this is also things that are easy. We want to, do things like, an individual's limited in time. It wouldn't be reasonable to ask the geriatric nurse practitioner or pharmacist to see every patient every day. But 2 times is easy and doable. And that's also going to be another hallmark of successful interventions. And then, as we saw from this example, reflecting on what's working, what's not working, what can you learn, whether your intervention is moving forward as you had thought it would or not. Learning from that experience is really critical. And when we put all these things together, there's really a huge potential for impact, especially over time, working through these projects. I want to transition now to share with you all the impact of this Quality Improvement Collaborative. When we initiated this in the summer of 2021, it was still relatively early in the pandemic, and the focus was very much on COVID-19 prevention and infection control, so much so that that was in the title of the collaborative. But from the beginning, and certainly over the last 18 months, facilities have chosen to focus on certain issues that weren't all related directly to COVID-19. And I shared with you what some of those common initiatives were. And now I want to tell you what impact it has actually had on the health of residents in nursing homes around the Middle Tennessee area. Let me start with one of the process measures that was important in the beginning of the pandemic, which is vaccination rates. I'm going to show a series of 3 graphs, each of which has a different outcome. And in this first graph here, just to orient you, because the next graphs are going to be the same format. What we've done is we've got in a red line the facilities that participated in the Quality Improvement Initiative. And in the blue line, those are other facilities in the region that didn't participate in the Improvement Initiative. And what we're going to see on the x-axis here is time. So we started our work around August 2021, but really the main period of implementing improvement initiatives started November to January, that winter. And so I'm just highlighting that as a key period where, over this period of about 3 months, facilities, just as they were able to start things up, not every facility started in the same date, but certainly over that 3-month period in particular, we saw a lot of improvement projects roll out. One of the measures we were really interested in affecting is vaccination rates for COVID among residents. We actually didn't make an impact here. There are a couple of reasons for this. One is all facilities raised the bar. And what we saw over time is that across all facilities, participating and non-participating, the rate of vaccination for residents pretty quickly reached about 80%. And it actually got to that point even before we started doing much work across the region. Remember, our initiative started here at the earliest, August 2021, and the main period of work was here. And what we saw is resident facilities had already kind of reached their level that they were going to reach at that point. There wasn't a whole lot of room to go up, but facilities did maintain a pretty steady level of vaccination over the subsequent months. Another measure that we tracked is healthcare workers receiving vaccination. Again, vaccines became available, back here in the middle of 2021, and the healthcare workers and facilities started seeing vaccines. They started getting more and more vaccinated, and by the time we started working with facilities, the vaccination rates among staff were already on the rise, and especially during this winter, facility staff really reached about an 80% level of vaccination. And this is regardless of whether or not they were a participating facility. All facilities saw the importance of staff vaccination and everybody raised the bar. The third main measure we tracked is what happened with hospitalization rates. Here, there was some very noticeable improvement. Again, to orient you to this graph, the red line shows facilities that participated in this quality improvement collaborative, and the blue line is facilities that didn't, that are also in our region. And I want to first draw your attention to the left side of this graph in the 2021 months, because that's really before the initiative got going. We found that facilities that ended up participating actually had a higher rate of hospitalizations than facilities that ended up not participating in the collaborative. What we saw is that as sites became more trained in quality improvement methods, started doing projects this winter, the curves actually flipped. That facilities that were participating in the collaborative now started having lower hospitalization rates in red than facilities that didn't participate in the collaborative, which are shown in blue. And that was consistent for the next year, all the way up almost to present. Here is January 2023 on the right of this graph. And this was a really positive finding, one that made us very proud of the work that we all did together. And the hospitalization rates going down this much among participating facilities is probably a combination of many factors all improving. So what could some of those individual factors have been? This table shows different MDS outcomes. Here we've got one column here for participating facilities, and then this other column is that same control group of facilities that didn't participate that are located in the region. Again, for orientation, numbers in green are better and numbers in red are not better. What we found is, and these things may have all sort of added up to contribute to the lower rate of hospitalization. But what we found is, looking at the MDS measures for participating facilities, they were able to achieve lower rates of pressure ulcers. They were able to achieve lower rates of falls, lower rates of weight loss, lower rates of anti-anxiety and hypnotic medication use, and lower rates of antipsychotic medication use. Those are all the things in green. There were some things that didn't get better. The rate of pneumococcal vaccination was already pretty high. It didn't get better in participating facilities. In fact, it was a little bit worse. And the influenza vaccine that also wasn't better in participating facilities. I don't have a great explanation for that. We did have an educational program on vaccine use. I don't think this was a major focus of improvement efforts within facilities, whereas we do know that facilities worked on pressure ulcers, nutrition, falls, and medication management. So those things that facilities worked on commonly um, were better in the group of participating facilities. And not a lot of places worked on depressive symptoms either. So that one, um, wasn't any better among the participating sites. But there were several MDS measures that really seemed to improve, likely as a result of initiatives that were taken on by the participating sites. And that's great to see. So these are the main outcomes here. This hospitalization rate is one of the main things we're looking at. I feel like this was a success in reducing hospitalizations. Also a success in improving MDS outcomes, particularly for those topics that facilities chose to work on. We know that facilities, or we hope that facilities are going to continue engaging in quality improvement efforts. Our project has been funded through the end of March. So we're not going to be able to continue doing the one-on-one support with facilities that we have. But I do want to be sure to raise awareness of some resources that are going to be available, some of which we've compiled to provide ongoing support to facilities in your continued improvement journey. These resources are all online. I'm just going to show you the web pages here. And first of all the webinars that we've developed for this collaborative have been recorded, and they're all archived here on this website. So if you use your favorite search engine and just look for Vanderbilt Center for Quality Aging, you'll quickly come to this site where we've archived all the materials under our COVID-19 collaborative. And you can see in most cases they're little videos, and it's monthly webinars that can provide a great source of staff education. We tried to make these all hands-on. We tried to make them all practical and include examples of improvement projects in each of these areas. And the topics range, as you can see, from mental health and resilience to medication management. There's one on pressure ulcers, another one on falls prevention, weight loss prevention, long COVID. There's a lot of topics that you all in the facilities told us were most relevant. And so really tried to focus the educational offerings on those areas. And they're all here for you. We're going to be maintaining this. And please do feel free to share this. We're also going to distribute it, hopefully, in a statewide newsletter so other facilities can have access. Another resource is not developed by us, but we do want to share it. It's Project ECHO. I know many of you are familiar with that. This was kind of a national initiative working with nursing homes, kind of like ours regionally, but this was national, not as high touch. It was a little bit lower touch, and it was sponsored by the Agency for Healthcare Research and Quality. So they have a website for their Project ECHO materials with some other resources that you might find helpful going forward. And the last thing I want to share is the Institute for Healthcare Improvement. So the IHI not only has great tools for doing quality improvement projects, like we went through today, the IHI model for improvement, root cause analysis, things like that, but also some specific guides around caring for older adults in the context of the pandemic. Even though we're nationally declaring an end to the emergency state of the pandemic, clearly it's going to continue to affect the health of elders around the country, particularly in nursing home settings. And you may find some of these resources helpful for supporting your residents and for supporting the staff working in your facilities going forward. So I'm going to end there, and I'm going to stop screen sharing. And again, I want to thank you all for your involvement in the collaborative. We've got several team members here who I want to acknowledge as well. Isaac Schlotterbeck is our program manager, and Gallion, one of our nurse practitioners, Christina Niehoff is our pharmacist. And I know that there are a number of other participants on, of course, Carol Bartu, who spoke and gave the 2 examples. Sure, any of us would be happy to answer questions that you might have. So please do feel free to unmute if you'd like to share anything about your experience working in the collaborative. Comments are welcome. If you have any questions for us, let's unmute and offer some time for questions. I do want to remind folks that we've got continuing nurse education credit for this session, as we'd offered with past sessions, and Isaac has put that information in the chat. So you can link out to that survey for having joined today. And if you have comments later for us, I know we're interviewing some participants to learn from your experience being in this collaborative so that we can share those general lessons learned with others who do this type of work. Again, thanks for being part of the collaborative. We're going to have these resources available to you for the future, and feel free to drop us a line anytime, either to me or to Isaac. I'd be happy to provide any additional resources or support as needed. And thanks again for joining today.
Awesome. Well, yeah, like Dr. Kripalani said, please feel free to send any questions directly to him or to me, and we can make sure they get answered as best as possible. And if there's no specific questions that anyone wants to raise today, we can just go ahead and end the call a few minutes early. All right. Well, awesome. Well, thanks, Dr. Kripalani, and thank you everyone for participating and for everyone who joined the call today. Hope you all have a great day.
Take care.
Take care.